You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. This is This Week in Cardiology for October 14th, 2022. This week, chest pain evaluation in the emergency department, peer review, NordICC trial, and a surgeon lost too early. First up is chest pain in the emergency department. The ACC has issued a 32-page expert consensus decision pathway for the evaluation of patients in the emergency department for chest pain. Some of the key points of this document are: the ECG remains the best initial test. Doctors should also look at the pre-hospital ECG, and patients without ischemia can enter an accelerated, quote, clinical decision pathway, which is designed for rapid risk assessment. High sensitivity troponins are the preferred biomarker. There are lots of pathways depending on your high sensitivity troponin, and patients can be called low risk, moderate risk, or high risk. And of course, there's mention of the heart score. The document is the second major paper on the emergency department evaluation of chest pain that's been published in recent months. Last October, Dr. Martha Gugliotti and colleagues published guidelines on the issue. Now, this current expert consensus paper is fine. It's well written, and there are colorful, pretty charts. But here's the thing, and I might be showing my age. I am not so sure pathways and systems are going to add much in the diagnosis and treatment of people with chest pain. For instance, I'll tell you a story. Maybe I've said it before in this podcast, but in any event, a few years ago, before I knew anything about a heart score, I didn't even know it existed. An emergency medicine doctor called me up to tell me about one of our patients who was in the emergency department with chest pain. Now, this man had had 2 bypasses, 15 stents, he still smoked, he had an ejection fraction of 15%, a creatinine of 3, a BMI of 33, a history of VT storm and ICD shocks, and multiple ablations and chronic amiodarone use. That he was alive and in good spirits most of the time is a matter of providence. Well, the emergency room doctor tried to tell me his heart score, and I stopped him. I said, "Sir, I don't know what a heart score is, but this man's score is infinity." Instead, I asked the doctor, "Do you know what could be wrong with him?" Now, before the pandemic, when I visited Scotland, the senior doctor there, Dr. Andrew Flappin, would tell me and others that high risk or moderate risk is not a diagnosis. A PE is a diagnosis. ACS is a diagnosis. Non-cardiac chest pain is a diagnosis. High risk is not a diagnosis. Now, another matter is the ECG. The document rightly tells clinicians to get an ECG, and then also to look at the pre-hospital ECG. And of course, this is great advice, but the issue is not in looking at the ECG, it's interpreting the ECG properly. And this is a huge problem. Now, you can't learn ECG interpretation from a consensus document. You learn how to read ECGs by studying and practicing and having mentors. I wish the document would put in huge letters, never look at the computer reading. If we didn't have computer readings on these ECGs, ECG reading would be better. ECG readings on the top of ECGs is a lot like causal inference from observational studies. Sometimes it's right, you just don't know when. Okay, back to the clinical evaluation and this business about scoring systems like the heart score. Better than that would be visiting with the patient and listening, really listening. The history, exam, ECG, high sensitivity troponin should almost always be enough to make you worried or not worried. Don't think about risk. Think what infirms the patient in front of you. Finally, and I'm going to close this with one of the most important philosophical issues to ponder when we think about emergency department adjudication of chest pain, and that is how many MIs or PEs are we willing to miss? If the answer is 0, I'm afraid there will be trade-offs and harm from overdiagnosis. Second topic is peer review. A delicious paper came out a few weeks ago that delved into the bias inherent within peer review. Now, I started doing academics about 10 years into private practice, and one of the most surprising aspects of this has been the discovery of peer review. Wow, I had no idea. Now, there's so much weight given to peer review in the media. Journalists, for instance, will use peer review as a positive modifier, as in, this was a peer-reviewed paper. There's also the negative connotation of preprints, as in, this paper has not yet passed peer review. Yet there is little to no empirical evidence that peer review ensures quality science. And that's not me talking. I'll link to a Cochrane review of 29 studies that concludes exactly that. Former JAMA editor-in-chief Drummond Rennie once said about peer review, if peer review was a drug, it would never be allowed onto the market. Peer review would not get on the market because we have no convincing evidence of its benefits, but a lot of evidence of its flaws. Now, one of the reasons for this could be bias, and that is where the new paper comes in. The authors from Austria were interested in status bias, meaning prominent researchers get outsized leeway, while unknown researchers get little credit. They measured status bias by sending a paper to more than 3,300 researchers. Now, this was in the economic sciences, but it could be in any field. In one arm, they had a Nobel laureate author the paper. In another arm, they credited the paper as an early career research associate who had only 42 Google citations. And in the third arm, the paper was anonymous with no study authors listed. And boy, did it make a difference. While only 23% recommended reject when the prominent researcher is the only author shown, 48% do so when the paper is anonymized, and 65% do so when the little-known author is the only author shown. It was worse to be little known than to be anonymous. Now, we need to do this in medical science. I would bet my Pinarillo that we'd see the same thing in our field. And of course, I don't know the answer for reducing bias in peer review. There are no easy solutions. Anonymous review has its issues. Publishing comments along with the paper is a decent idea, but again, peer reviewers might be afraid to write frankly. I, for instance, am sometimes afraid to write frankly. I guess the main and concluding point here is not that peer review is worthless or that it should be eliminated, merely that us, consumers of science, should not count on peer review to do the work of critical appraisal for us. And for Pete's sake, journalists should stop using, quote, peer-reviewed as code word for settled science. It clearly is not. All right, third topic today is the NordICC trial. Now, I want to discuss the NordICC trial, which is an RCT of colonoscopy for prevention of colorectal cancer, and I know you say it's not cardiology. Well, I will justify my discussion on 4 grounds. One is that, as a cardiologist, I receive, as you probably do too, near daily messages to request permission for interruption of oral anticoagulation for a GI procedure, often a screening colonoscopy. The second reason to discuss this trial is that it's a tour de force in trial interpretation, and that is a core focus of the TWIC podcast. Now, the third reason I want to discuss this is that prevention measures always deserve thought and a higher bar of evidence. Recall that Wilson and Younger argued in the 1960s that screening for disease was, in theory, admirable, but in practice, there were snags. And the fourth justification is that there are important similarities of this NordICC trial to the Dankavas trial, which is a cardiac screening trial that I've discussed previously on the podcast. Now, before I say anything about NordICC, I want to refer you to a short essay from the great David Sackett, the founder of evidence-based medicine. I'm going to link to it, and the title of it is The Arrogance of Preventive Medicine. And I want to say thanks to Dr. Ken Milne for the citation. Please do read this essay and pay particular attention to who Dr. Sackett places the most blame on for some of the failures of preventive medicine. And staying with Wilson and Youngner's theme, it is indeed admirable to attempt to prevent colon cancer. It's both a bad disease and a potentially preventable disease. Of course, the dominant form of prevention in the U.S. is colonoscopy. But it turns out that before the Nordic trial, there were exactly 0 trials of colonoscopy. In randomized controlled trials, fecal occult blood testing, or FOBT, has been shown to reduce deaths due to colon cancer, but not overall survival. Flexible sigmoidoscopy shows both a reduction in colon cancer death and overall mortality, actually. Now, here are the details and results of Nordic. About 85,000 individuals were randomized in 1-2 fashion to be invited to screening colonoscopy or not in Poland, Norway, and Sweden. Individuals were randomized before they were asked to participate in the trial, and that meant that they had to decide to attend screening if they were randomized to that group. More on that in a bit. The primary endpoints of Nordic were colon cancer diagnoses and colon cancer death. Okay, the chance of getting diagnosed with colorectal cancer in the invited group was 0.98% versus 1.2% in the usual care group. This represents an 18% relative risk reduction and an absolute risk reduction of 0.22%. The chance of dying from colorectal cancer in the invited group was 0.28% versus 0.31% in the usual group, and these were essentially the same and not significantly different. And 11.03% of patients died in the invited group versus 11.04% of patients died from all causes in the control group. The New England Journal of Medicine conclusion from the authors said, in this randomized trial, the risk of colorectal cancer at 10 years was lower among participants who were invited to undergo screening colonoscopy than among those who were assigned to no screening. They didn't say anything about colorectal cancer deaths. The editorialists write, quote, this relatively small reduction in the risk of colorectal cancer and the non-significant reduction in the risk of death are both surprising and disappointing. Okay, now to the fun part, the critical appraisal part. There were a reduction in cancer cases, but the absolute difference was small, 0.22% absolute risk reduction in getting a diagnosis of colon cancer. That's an NNT of 454. There was no significant reduction in death due to colorectal cancer, and there were no differences in overall survival. And a neutral Martian would look at this and say, this is clearly a neutral trial, especially relative to the fact that FLEX-SIG, which has RCT evidence of both disease-specific death and overall survival, and is less invasive and less costly. But there were nuances, and of course the American Gastroenterology Association issued a press release on the talking points about this trial. And the first issue they raised was the invited to screening versus getting screened. Now, only 42% of those invited to screening actually had the procedure, a colonoscopy. And you can't benefit from a test if you don't get it. And this was actually similar to Dankavas, where only 62% of those invited to cardiac screening had the cardiac test. Now, the Nordic authors, unlike the Dankavas authors, did a per-protocol analysis, which is defined as the effective screening if all the participants who were randomly assigned to that invited group actually had undergone screening. Now, this requires balancing of covariates, much like what is done in non-randomized observational data sets. And in this per-protocol analysis, screening looked a sliver better. The risk of getting colon cancer went from 1.22% to 0.84%. That's a 31% reduction in relative terms, but with 0.38% absolute risk reduction. The number needed to screen went from 455 in the intention to screen main analysis to now 263 in this analysis. And in the per-protocol analysis, the risk of death from colorectal cancer was 0.15% in the invited group versus 0.30% in the usual care group. The editorialists write that this is a 50% reduction in relative terms, But in absolute terms, the risk difference is 0.15%, or 15 per 10,000. And that's a number needed to screen of 660. 660 colonoscopes to prevent one colon cancer death. And of course, this is a biased estimate because those who go to screening may be healthier, they may be richer, they may eat better foods. That is why we use intention to treat comparisons. In fact, in Dankavas, which was also an invited to screening trial, 62% of those invited to be screened actually had the screening test, so 38% did not get screened. Dankavas found not a 0.5% difference in mortality, but a 5% reduction in overall death in the invited to cardiac screening group. There was no mention in that paper about looking at those who were actually screened in a per protocol analysis. And I actually asked PI Axel Didrikson about it, and he grinned and said something very Danish, like, "Of course, that would not be right." Now, another criticism of Nordic gets to its external validity or generalizability to other populations. Colonoscope proponents were quick to point out that about a third of the Northern European proceduralists had adenoma clipping rates below American standards. Basically, this argument held that gastroenterology in Poland, Norway, and Sweden is inferior to American gastroenterology. Now, I'm not sure that I can recall a similar story in cardiology where Americans diss the quality of care in their European colleagues. Also, and I'm not sure this is relevant, you tell me if it's relevant, pathologist Dr. Ben Mazur wrote that American doctors get paid more to clip more adenomas. A wink there. And a final criticism of Nordic is pretty valid. And that was it takes more than 10 years to realize a difference. And again, it's fair and also pertinent to cardiology, wherein we run very short duration trials. I strongly suspect that you'd see larger effect sizes of some of our preventive therapies if you ran trials longer than, say, 3 to 5 years. Think statins, think RAS inhibitors, and heart failure. And my final comment is that billions of dollars, billions, are spent doing colonoscopies. Hospitals and doctors are enriched by this procedure. But this study strongly suggests that if there are any benefits, they are tiny in absolute terms. And the This Week in Podcast always likes to remember that money spent on low-value care is less money available for basic care. All right, final topic today is Domenico Pagano. European heart surgeon Domenico Pagano died on October 10th, right after the close of the European Association of Cardiothoracic Surgery meeting, EACTS meeting. A close friend of his said that he had advanced cancer and presented to the hospital during the EACTS meeting. Professor Pagano knew he was terribly ill but did not let anyone know he was in the hospital for fear of disrupting the meeting of the organization that he once led and loved. Pagano is special because he was, as Steve Stiles writes, a champion of evidence-based medicine. We had had many communications about the state of medical evidence and guidelines, and I'm proud to have co-authored a paper with him in the Journal of the Royal Society of Medicine this summer. We wrote about the path for medical associations to sponsor trustworthy guidelines. Pagano was especially concerned about the interweaving connections between industry and trials and professional organizations and guidelines. In our paper, which he was the first author, we pushed for transparency. We pushed for more robust ways to deal with conflicts of interest and more input of independent reviewers. And of course, he was right. Medical associations exist because of industry funding. Medical associations, therefore, will always be pro-industry. Now, you think those glitzy expos, the ones with a Xarauto race car in them, you think they come cheap? Professor Pagano's outspoken nature long preceded our guideline paper. He led the way regarding the controversy surrounding the XL trial, the left main stents versus bypass trial, which was plenty of controversy, and I won't re-adjudicate it here again. During that time, we spoke many times on the phone via WhatsApp. I'd be in clinic and he would call. He was so passionate, so Italian. Even without having him on speakerphone, others could hear him. I love this passion. He was like a European Bernard Lown. And final comment His early death makes me think about how precarious and precious life is. You don't know when it is your time. You can't control it. You can't cheat death. I try to remember that as much as possible. While I'm not a huge fan of the New York Times writer David Brooks, he once wrote something very good, and he wrote about resume values versus eulogy values. And of course, resume values are your achievements, your publications, your invited lectures, your CV. Eulogy values is what they say about you when you die. And I'm sure Pagano had a great CV, but his passion for trustworthy medical evidence is one hell of a great eulogy value. And my condolences to his family and his friends. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating. Even a 1 or 2 sentence review goes a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.